So let's talk about diabetes management. So clearly the goal is to avoid the complication, acute complication of diabetes, diabetes ketoacidosis, hyperosmolar state, etc. But also to prevent the micro and macrovascular complication, minimize hypoglycemia, and increase quality of life. And as we remember, so this is typical level in an uncontrolled type 2 diabetic patient. I apologize, this is in milligram per deciliter, but compared to a normal individual in which glucose levels are nicely compensated and they have a small increase after breakfast, lunch, and dinner, in patient with type 2 diabetes, the levels are much higher, they have higher magnitude excursion. We have a lot of medication. I'm not going to go over this, but they can work in different mechanisms at the pancreas, at the muscle with the insulin resistance, liver, gut, and now also with kidneys. So there are a lot of agents, and there is not a huge consensus in which are the best agent for treating diabetes. This is nothing that you really have to look at, but it basically showed that most recent American Diabetes Association guideline, in which basically patient with type 2 diabetes, the idea is to start with metformin, and then most patients will fail and add another oral agent to metformin. We'll talk about this a little bit later on, triple therapy, injectable, there are a lot of medication. So the first step, why we're using metformin? Because metformin is powerful, does not induce weight gain, does not induce hypoglycemia, is usually very well tolerated, and is actually reasonably cheap and convenient. And if you just do diet and exercise, just intervention alone usually fail to maintain these goals. Old studies show if you take patient on diet and randomized to placebo or metformin, you can decrease hemoglobin A1C by 1.5% with metformin alone. But then when we follow patient on metformin as a monotherapy, and if you follow them, and this is in months, so if you follow them for 4 or 5 years, almost more than 50% of them fail monotherapy. It's not that they are doing anything bad, it's just that the pancreas kind of slows down and there is less and less insulin secretion. So second line agent that we use quite a bit, of course, are the sulfonylureas. We use a lot of glipizide. We don't use much glyburide anymore just because of it is renally excreted, and patients that have an abnormal creatinine clearance can become severely hypoglycemic. And if we look at the data in terms of the same study in which patients were randomized to metformin, but then when they were failing a single agent and they were randomized, failing metformin, they randomized metformin plus glyburide, there was an additional decrease in hemoglobin A1C. So these are powerful drugs. And this is actually an old study from 2002, but if you look at oral hypoglycemic agent, and this is decreasing A1C by percent, the two most powerful are sulfonylureas and metformin, then thiazolidine, meglitinides, and alpha-glucosidase inhibitors. So usually we start with monotherapy with metformin, unless the hemoglobin A1C is really high, then we can start with 2 agents. Or if the A1C is higher than 10, then the current recommendation is to start with injection. And then to move quickly, and if the monotherapy is not effective, to proceed to dual therapy, etc. And then eventually, most patients will down the road require some insulin. And let's talk a little bit about insulin. We have many different insulin. This is an old slide. Now we also have newer insulin. We have Tresiba that is available. But if we look at the old NPH and regular, and the profile is what we use quite a bit for type 2 diabetes. Clearly, some of these new analog are much advantageous for type 1 diabetic patients. For type 2 diabetes, I'll show you a few studies show that there is not a huge difference. So this is a study that I found fascinating. It's a very old study from Finland, 1992. But they randomized patients with type 2 diabetes with sulfonylureas and morning NPH, bedtime NPH in yellow, twice a day NPH in green, 4 times a day insulin. And as you can see, there was really no difference as far as insulin was given. And the important thing is shown in this also old slide, in which 12 patients with type 2 diabetes were started on bedtime NPH, and this is plasma glucose level that over the 16 weeks came down to normal. But the amount of insulin that was required was a lot, 85 units. And with this, pretty much every patient was able to decrease A1C from 10.7 at the beginning to 7.2 at the end. Another study that I found it very interesting was published in 2003, as was the treatment to target, in which almost 800 type 2 diabetic patients who were failing oral therapy were randomized to either NPH versus Lantus, starting at 10 units at bedtime. And they were titrated very quickly every week. And this is basically what happened to their A1C. The A1C that started at 8.5 after 24 weeks came down to 7, and there was no difference whatsoever between bedtime NPH or bedtime glargine, Lantus insulin. And about 60% of patients achieve an A1C at goal with only one single injection of insulin. There was a slightly increased incidence of nocturnal hypoglycemia with NPH, but was really minimal. Now, of course, there are also these 40% of patients that did not achieve an A1C at goal with one injection of insulin. And then we are going to talk about multiple injection. And this is another study in which they compare patients that were taking pre-mixed 70-30 insulin versus patients that were just on a basal insulin and patients that were on a basal and prandial insulin, so 4 injections a day. And as you can see here, the changes in A1C was a little bit better if you use prandial insulin. But if you look at the right-hand side, the risk of hypoglycemia was also much higher, especially with prandial insulin. And there was also a little bit more weight gain. And when they follow this patient, not just for the first 6 months, but for up to 3 years, after 3 years, there was not a huge difference between the different agents. So we can use a very different regimen, the twice a day regular NPH. And this is the normal pancreas in a normal individual. Insulin secretion after breakfast, lunch, and dinner, as you can see, is not easy to mimic this with multiple insulin injection. Other regimen could be, again, the same, taking short-acting insulin like Lispro or Aspart at breakfast, lunch, and dinner, and twice a day NPH, or the most type 1 friendly, taking a basal insulin like Glargine, Tresibana, or Detamir, and then short-acting insulin at meal. That is the most labor-intensive and costly insulin regimen. So in summarizing insulin, basal insulin is effective to lower fasting glucose level when there is still significant beta cell function. But when the beta cell function decreases, and I have measured, for example, C-peptide in a number of type 2 diabetic patients after many years of diabetes, it can be almost undetectable, almost close to a type 1 level. Then there is also the need to control prandial hyperglycemia with some prandial insulin. And so instead of increasing the amount of basal insulin, you need to also start adding prandial insulin. And of course, to assess adequacy of prandial insulin, checking 1 and 2 hour post-meal glucose level is kind of important. So some of the common regimen that we use is NPH plus regular at breakfast, regular at dinner, NPH at bedtime, or regular and NPH at bedtime. We also use a lot of pre-mix insulin twice a day or sometimes 3 times a day, depending on the pattern of meal, or a long-acting insulin and rapid insulin at each meal.